Okay. You might leave it, Jenna, you might just leave that door open.
Okay.
We're just going to leave it wide open and try to get what we can get. Okay, let's look at your differential diagnosis for PTSD. There are some diagnoses that we'll actually look at on Thursday, but malingering is one. Factitious disorder is another. We're going to look at adjustment disorder here in a minute, but it could be depression, anxiety disorder, borderline personality disorder, substance abuse, mental disorder that's organic, and then you note that comorbid psychiatric conditions are common. For example, they could have a generalized anxiety disorder and that. They could have depression and that. They could have personality disorder and PTSD. The therapy for PTSD is cognitive behavioral therapy. Cognition, again, helps the person kind of reframe, process the memories and negative expectations. So you have to help them rethink it, retrain, and develop a new pathway when thinking about those thoughts. And then behavior therapy deconditions PTSD patient by using relaxation with systematic desensitization to the things that are a problem, like the sound of a helicopter, a crowd gathering around. Medications that are used, there's a wide range of things that are used. Antidepressants, all of our favorite friends again, adrenergic blockers for symptoms, mood stabilizers, anticonvulsants, anxiolytics, antihistamines, and even atypical antipsychotics. A lot of therapies that I don't think anything is really completely well understood. Okay, let's look at acute stress disorder. And this is somewhat, these disorders, these stress disorders are somewhat analogous to the schizophrenia, where you had schizophreniform, schizophrenia, brief, psychotic disorder. They were all based on length of time that a person had it, and these are somewhat in the same vein. So there's distinctions. PTSD is a little bit longer. It's at least a month. Now here, this one is acute stress disorder, exposure to actual threatened death, serious injury, sexual violation, not so much unlike PTSD, in one or more of the following ways: direct experience, witnessing, learning about it for a close family member, experiencing repeated or extreme exposure to aversive details of traumatic events, like a trauma worker, or a EMT, etc. In this one, you have to have the presence of 9 or more of the following symptoms from any of the 5 categories of intrusion, negative mood, dissociation, avoidance, and arousal, beginning or worsening after a traumatic event. So it's not like PTSD where you have to have this, and this, and this, and this. This, you have 9 symptoms you have to identify, and they have to come from these 5 categories. You could have 1, 2, 3, 4 from intrusion, 4, 5, 6, 7, 8, 9, okay, from those, and then no arousal symptoms. So you see what I'm saying? You've got these 5 big categories. You have to have 9 or more from any of those categories. The intrusion symptoms are the same types of things we just talked about: memories, dreams, flashbacks, intense psychological distress or physiological reaction to triggers. So it's that type thing. Negative mood, persistent inability to experience positive emotions. Dissociative symptoms, an altered sense of the reality of one's surrounding, inability to remember an important aspect of the traumatic events. And Fong was asking about that because I'm not sure I made that clear. It's not uncommon in a person with PTSD or in an acute stress disorder to remember the bad thing that happened, but maybe not remember all the events that led up to it, because the event is so traumatic, it just burns your memory on this piece of it, so you may not remember all the things that took place. For example, in the Vietnam PTSD I'm talking about, where somebody sees their friends blown up by a hand grenade, they might forget that they said, "Run here, let's go here," and they chose to go another direction, so they were actually trying to help. Or maybe they actually pulled 2 people with them before the other 10 people got blown up. they won't remember that they said come here or that they pulled 2 people with them. All they can remember is that people died. It just locks down right there. So the therapy a lot of times is aimed at helping them recount all the steps of what happened so that you have a more complete picture. But those events are so traumatic when they happen that your brain does not hold and process all of the incoming information the way you would any other time, is probably the best way to describe it. They have dissociative symptoms, the same thing that we talked about Ptsd, and then they have avoidance symptoms and arousal symptoms, which are usually sleep, behavior, angry behavior, irritable behavior, hypervigilance, problems with concentrating, exaggerated startle response. Now here's the differentiation. The duration of the disturbance is 3 days to 1 month after the trauma exposure, so it's a tighter range. PTSD has to be at least 1 month. This could be 2 weeks and done, and it would work, by definition. They begin immediately after the trauma, but persistence for at least 3 days and up to a month is needed to meet the criteria. So all you have to have is 3 days. So after the Merle building bombing, there could be people who had these things immediately, and they would have the diagnosis of acute stress disorder. Now, if it persisted and moved forward, then you might eventually ultimately change your diagnosis from acute stress disorder to post-traumatic stress disorder. So it's one of those things where your diagnosis right now is this, but if it goes on for years, then it goes to something else, and you just change the diagnosis. And you see that with a lot of psychiatric disorders. So what is it like to have an acute stress disorder?
Anxiety disorders. They impact nearly 20 million people in America alone. In fact, they are the most common psychiatric disorders affecting both children and adults. And with the increasing stress of living in the 21st century, on both a global and personal level, this subject is getting more attention than ever. There are several anxiety disorders identified in the Diagnostic and Statistical Manual for Mental Disorders, commonly known as the DSM. Though they share a common theme of excessive, irrational fear and worry, each anxiety disorder has its own distinct features and challenges. In this program, we are going to explore acute and post-traumatic stress disorders. Vicki was coming home one evening when she was assaulted and nearly raped. She now suffers from acute stress disorder, a condition that reflects the anxiety and behavioral disturbances that develop within the first month after exposure to an extreme trauma.
Can you talk about it, Vicki? Are you comfortable talking about it?
As with all of the anxiety disorders, there are several criteria found in the DSM that establish what constitutes acute stress disorder. Much of these are shared with post-traumatic stress disorder, which will be discussed later.
What did I do to deserve this? I must have done something.
You were assaulted, Vicki. No one deserves this.
The first criteria is that the person has been exposed to a traumatic event in which both of the following were present. 1. The person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others. 2. The person's response involved intense fear, helplessness, or horror. This can come from a variety of experiences.
So you see this in soldiers who have been exposed to combat. You see this in refugees, and you see this in people who have had dreadful car accidents or witnessed dreadful car accidents.
We see a lot of people who are rape victims or have gone through physical abuse or sexual abuse.
The next criterion set either while experiencing or after experiencing the distressing event, the individual has 3 or more of the following dissociative symptoms. 1. A subjective sense of numbing, detachment, or absence of emotional responsiveness. 2. A reduction in awareness of his or her surroundings, such as being in a daze.
Do you know how you got here today?
The third symptom is called derealization, which refers to an alteration in the perception or experience of the external world so that it seems strange or unreal.
Vicky, you just don't seem like yourself. I've never seen you like this. Like what?
For example, people may seem unfamiliar or
That's enough. I guess that's going to be about it for her. One thing that's kind of interesting about this is why are they in the daze? Why does she not know how she got there? You kind of wonder, how does that happen? And I think part of it is the fact that they are so distracted and so focused on what happened, they can't think about anything else. You know, when you're driving your car and you're thinking about something, and all of a sudden you realize you're at a place and you don't remember anything about how you drove from here to there, and you're thinking, oh my God, I'm gonna have a car wreck and kill somebody. But you're kind of on autopilot doing the things you do, but it doesn't stick in your brain that you did it. And I think it's somewhat like that for these folks. Kind of scary. Therapies for acute stress disorder is cognitive behavioral therapy, and of course pharmacotherapy with all of our friends. You don't need to worry about this. High-dose glucocorticoids, morphine, just SSRIs probably are your number one thing with cognitive behavioral therapy. And then the final one is adjustment disorder, and this is a very common diagnosis, and that's the reason why we're going to end up with this one. It's development of emotional or behavioral symptoms in response to an identifiable stress or stressors occurring within 3 months of the onset of the stressors. Symptoms are clinically significant as evidenced by one or both of the following: marked distress out of proportion to the severity or intensity of the stressor, and that takes into account cultural and contextual factors. Some cultures respond differently than others, so you can't judge somebody in another culture. Is that response markedly out of proportion? It may be in proportion. Give an example of that cultural difference. I had a student one time who was being dismissed from the College of Pharmacy, and she was from Nigeria. And of course, I mean, that's a major distressor. That is a terrible, terrible thing. I have to get into the right frame of mind to be involved with something like that. But their proportion for this was beyond what you would think is ordinary in America. And I was warned about this from somebody, but it was my first experience. There will be wailing and shrieking. She came to the office with her husband and her family, all the children clinging to her. And there was crying and begging. Got on the floor and grabbed your ankles. I mean, it was like, oh my gosh. And I'm glad somebody told me, because I wouldn't have known what to do with this. But this was the cultural expression of grief to try to lean you to something else. And as soon as you said, please, don't do this anymore, this is enough, they got up and just were completely normal. So it was almost like it was, I wouldn't say it's an act, but I would say it's the normal way to approach that, and it really threw me for a loop. And that's true for a lot of different cultures, like death responses, to loss of loved ones, big tragedies, different. So for this diagnosis to happen, the response has to be something that is out of proportion to what's usually going on. Significant impairment in functioning. Okay, the disorder does not meet criteria for any other disorder, and the symptoms do not represent normal bereavement, because death with a response could be, you might put it into the category of adjustment disorder, but they have another one for that. I'll show you in a second. Once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. So it hasn't gone on for 3 months, but it doesn't last for more than 6 months after the stressor is gone. The stressor can be a single event, termination of a romantic relationship, or there may be multiple stressors like business difficulty and marital problems together. The stressor may be recurrent, that is, seasonal business crises. Every December we live on the beach and we have no money because nobody comes down here anymore. Or unfulfilling sexual relationships, one by one, it happens again for somebody. Or it could be continuous, a persistent painful illness with increasing disability, and there's an adjustment disorder with that. Living in a crime-ridden neighborhood. You'll see this in your practices because you will be dealing with people who have chronic illness that does not get better, and they may not all accommodate to it the way you might think they should accommodate to it, in which case it could be an adjustment disorder. And you'll see adjustment disorders on medical records a lot, which is like, okay, and let's look at further. They may affect a single individual or an entire family or a larger group or community. For example, a natural disaster, Houston gets flooded, Moore gets blown away by a tornado again, with all the thousands of people, who are involved with that. Some stressors may accompany specific developmental events like going to school, leaving home, getting married, becoming a parent, and retirement. And I know these don't sound like huge things, but these are big life changes. If you've never had a child and you have a child, that's a different household. And if you weren't prepared for what that was going to be like, there can be an adjustment disorder that goes along with that. Getting married. That can be a problem for some people because it's bigger than what they thought it was going to be, and the change is so significant. Retirement, going to school. There are people who go off to college who've never been away from home, and they really have a hard time. It's more than just being homesick. It's really not functioning on a number of levels. May be diagnosed following the death of a loved one when the intensity, quality, or persistence of the grief reactions exceed what normally might be expected, considering cultural, religious, and age-appropriate norms. There is a new diagnosis emerging called persistent complex bereavement disorder. DSM-5 doesn't really have it batched up under anything yet, but it's listed in the emerging or new diagnoses that are coming. So they're kind of grouping adjustment disorder around death of a loved one into a new diagnostic category. If the disorder persists for greater than 6 months after the stressor is ended, other specified trauma and stressor-related disorder could be used if the symptoms last greater than 6 months after the stressor is ended. So as long as it's within 6 months, it's an adjustment disorder. When you start getting out to beyond 6 months, that's when you start batching up under these catch-all disorders. So the time is important. 3 months in, no more than 6 months after the stressor is over, that locks you into an adjustment disorder. Look at the prevalence. 5 to 20% of those in outpatient mental health treatment have an adjustment disorder. And in an inpatient hospital psychiatric consultations, 50% of the people who are referred have adjustment disorder. Now think about it. You go to the hospital, you get a diagnosis of cancer. You go to the hospital, you have a cardiac condition, and you have lifespan predicted of X. Once that happens to you, then the person may not be able to begin to accommodate to this, or they've had the illness for a long time, and that fits them into the category. Then they get hospitalized for an episode in their illness, and they are just not adjusting or adapting well to what's going on. Now, who are we to say what good adjustment is? I'm just going to be a perfectly good little person, never complain on my way to the graveyard, and that's not the way people are going to actually look at it. Some of the symptoms: depressed mood, anxiety, impaired occupation, social functioning, agitation, physical complaints, trembling, palpitations, conduct disturbances. This is where it shows up a lot in clinic. Truancy, vandalism, reckless driving or fighting, or social withdrawal. I'll tell you, in primary care practice, if you are in family medicine and you've got like teenagers or others where they all of a sudden have big behavioral changes, You're always wanting to know what's going on in your world, because you want to, if it's not typical to be fighting all the time, what's happened? That child could be in the home of divorce, or mother could have died, and this is part of the acting out that goes on after that. Okay. Therapy, the goal of therapy is to relieve symptoms and help the patient establish a level of functioning comparable to that before the event. Psychotherapy in various forms can be used, from individual to family to behavior therapy, self-help groups, relaxation techniques. Lots of these have been mentioned even on some of the video clips. Medications are adjunctive only. Most adjustment disorders actually are managed without medications, and they can be used as adjunctive therapy, but you certainly would not want to replace the psychotherapy, which would be foundational. Anxiolytics, antidepressants are the things that are used. What's the course? If the symptoms persist, then the patient may be in the early phases of a major mental disorder that has not yet fully evolved. So almost with any of these disorders, what you see might lock down in that context and have a diagnosis, or it could be the beginning of schizophrenia, or the beginning of major depressive disorder, or the beginning of bipolar 1, the classic, it could be that. So a lot of times we really don't know what people are until we've been around them for a period of time, and then you begin to see the full expression of what's going on with that person. Remember, the adjustment disorders are common accompaniments of medical illness and may be the major psychological response to a medical disorder. And it can be quite notable. Okay, and I'll stop right there and let y'all ask me any questions if you have any at all. Any questions? I think it's time to move around quite a bit. So get out. This actually feels better with the doors open. Do y'all feel better?
Yeah.
So what do y'all want to do? Do y'all want to move or do y'all want to stay?
Stay.
Stay? Okay. All right, I'm okay. If we leave our doors open, y'all be okay? Okay. Y'all mostly just need some time to move around. So get out. I'll see y'all back at 1. Okay.